Public hearing on the House of Representatives Select Committee on Mental Health and Suicide Prevention. I'd like to begin by acknowledging the traditional custodians on the land in which we meet and pay my respects to elders past, present and emerging, as well as acknowledge other Aboriginal and Torres Strait Islander peoples with us today. I also acknowledge the cultures of any Aboriginal and Torres Strait Islander people speaking with us today and any who may be listening to this broadcast. I'd also like to acknowledge our veterans, our servicemen and women who sacrificed their lives for our freedom. This is the first public hearing of the committee's inquiry into mental health and suicide prevention, and the committee is inviting submissions by the 24th of March. Since the bushfires and COVID-19, our nation and indeed the world has not been the same. Lockdowns, restrictions and uncertainty about the economy, people's health and the future has caused people distress, and the landscape of mental health in our nation has changed as a consequence. The committee is unable to intervene on or provide advice in relation to individual circumstances. So if you are in immediate danger, please contact 000. If someone you know needs help, please contact Lifeline Australia, Suicide Callback, Kids Helpline, Beyond Blue or eHeadspace. In accordance with the committee's resolution on 24th of February 2019, this hearing is being recorded and broadcast on the Parliament's website, and transcripts of proceedings will be published on the Parliament's website. I remind members of the media who may be listening online of the need to fairly and accurately report the proceedings of the committee. So we have before us representatives from the Productivity Commission appearing today. For the benefit of the Hansard, could you please state your full name and the capacity in which you appear before the committee?
Stephen King. I'm a Commissioner at the Productivity Commission and was the lead Commissioner on the Mental Health Inquiry.
Julie Abramson, I'm a Commissioner at the Productivity Commission.
Rosalind Bell, Assistant Commissioner at Productivity Commission.
Thank you. I remind you that although the committee does not require you to give evidence under oath, the hearings and legal proceedings of the Parliament and warrant the same respect as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. Would you like to make a brief opening statement before you proceed to questions and discussion?
Thank you, Dr. Martin. We've provided the committee a written copy of an open statement and some slides. In the interest of time, would you prefer that I read it for Hansard or just that it's taken as given? I'm
happy for you to make that decision. We'll take it as given. That's
yeah, I think, and so over to you.
Okay, great. Thank you. Well, I think one of the questions that we have was in relation to private health insurers from funding community-based mental health care activities and permanent life insurers to fund mental health treatments for their insurance and clients on the discretionary basis. What strategies might be proposed to implement these actions? And that was the Productivity Commission's report, Actions 23.9 and 23.10 that I'm referring to.
All right. Julie, do you want to...
Thank you very much, Madam Chair. I think that the answer to that really was there needs to be, and I'm always looking to our Assistant Commissioner here, there needs to be a change, I think, to the Health Insurance Act to allow insurers to actually do that, and we certainly received a number of representations from insurers that were quite keen to actually be able to do that. Rosalind, did you want to add anything?
Yes, so with the private health insurance, we were primarily reporting on the need for more involvement of private health insurance in provision of community-based mental health services. As you would be aware, they are currently funding services in private hospitals, but there is a gap in the funding of community mental health services.
Okay. The report includes commentary on affordability and financial inaccessibility as both a barrier to treatment and prominent issue for many individuals. Would you like to, why are there no specific recommendations targeting this issue?
I suppose the general point that we would make, which goes to our report overall, is that we looked at it from a system-wide perspective. So we looked at it for the whole of Australia. And then we looked at some of the programs that were being delivered. But we did have a mind, especially early in the chapters in the report, which, you know, it's a rather large report, we did actually have a mind to the social determinants of health, and I know some of your committee members are very interested in that. But there aren't specific recommendations for specific groups of people, I think, in terms of financial issues. It's just the way we approached the report.
I think, and it's important to recognise that one of the differences, for example, between our report and the Victorian Royal Commission is that very much our report was about setting up a framework where, often at a regional level, there can be expertise at that regional level to work out, well, what are the barriers, how they best dealt with in this area, in this part of Australia, rather than recommending specific services or particular approaches to take. And that simply reflects the background that as economists rather than, for example, medical specialists, we wanted to make sure that we set up a framework where the experts could make the right decisions rather than saying, oh yes, this service is needed here.
I think the other thing, if I may add, is that we also saw a broader picture. So one of the most important things we think about our report is we looked very much outside health services, because we actually saw a lot of the things that existed outside of health were really important for people's mental health. So that's why you'll see an emphasis on community. You'll see a lot of emphasis on things like education, which I know, Chair, you're particularly interested in early intervention. So that's kind of how we framed our report. But we didn't really go down into the detail and say, well, what does this program do? What does that program do?
Okay. Deputy Chair, do you have any questions?
Yeah, I do. I'd like to thank the commissioners and the Assistant Commissioner for appearing before us today. What I was particularly interested in, given sort of the prevalence of mental ill health in Australia, and we're seeing that sort of not just through the lens of COVID, but bushfires and floods and other things that so many of Australians have experienced, there is a real sense of urgency in the community. So given the scope of your work and the, I think, over 105 recommendations, are there some particular recommendations that you think that could or should be, adopted with some sense of urgency or in this budget cycle, given the scope of the work and the urgency of the situation?
Well, we did. I'll let my colleagues assist me with this, but we did work on a prioritisation type, and we had a number of indicators for priorities, and I guess we all have particular views about it, but one of the things that really is very important is prevention and early intervention. So trying to deal at a system-wide level with kids in schools and with young people. So we have put them in a sequencing of events.
Perhaps also just to follow up on that question, I think there's a need to think obviously in budget cycles, and there's some recommendations that can be picked out for action in the short term, and in fact the federal budget last year had picked up some of the recommendations from the draft report which have flowed through to the final report, such as expansion of telehealth, although it's still got a deadline on it at the moment. But in many ways, because the recommendations often go to services that involve both federal and state and territory cooperation, almost the starting point has to be getting those foundations right. And so I think there needs to be, the key starting point needs to be the agreement between federal, state and territory governments as to really who's responsible for what and who's paying for what. And I think if we can move rapidly towards that and get agreement on that, that would really underpin all the reforms going forward.
The other thing I'd say is that the way we prioritised reforms, and I apologise, I just didn't have that in front of me before, was the potential to improve lives at either individual or community level, benefits to the economy and expenditure to achieve this, ease of implementation and sequencing. The other issue that, of course, is the really big issue is changing the culture around stigma and discrimination. So some of the things we knew that were really important, but that's really changing the way that society views those issues. But we did actually have a prioritisation, as I've just discussed.
May I have a follow-up question? Given this committee and the work that we're doing, is there any sort of a particular area where you think that we need more information, or is there any information that we should have available to us that currently isn't available, in order to go to your point, Commissioner, about the starting point about whose responsibility, who's the funder, but kind of taking that, is there more information that you think that we as a committee should have available to us, or that is critical to making those first steps?
I might ask Ms Bell if because she had to get all the information for our report.
In relation to, just taking a step back, in relation to the priorities for reform, I'd refer to the committee to the overview for the report around page 10, where we outlined particular priorities that could be done immediately, and as Commissioner King mentioned, that included telehealth. One aspect of that where we were lacking information was more information about community willingness to participate in telehealth. Now, subsequently with COVID-19 and the uptake of that, I think we have an answer to that, and we've seen considerable uptake of telehealth by both health professionals and by the community. So in that sense, there is now data available that we didn't have available at the time of the inquiry. The other aspect which we recommended should be looked at as a priority was adding rigour to individual mental health assessments and referral processes to enable people to actually make more informed decisions and have more information about evidence-based treatment that would be available to them with their particular circumstances. There was quite a lack of information in some places about the options that were presented to individuals and what choices they had available to them, and the knowledge of some of the health professionals making the referrals about all the options that they could refer people off to.
Can I just ask a question quickly on that? In terms of presented to individuals, the options available of evidence-based, who are you talking about? Medical practitioners presenting information to patients about evidence-based?
Clinical and non-clinical.
Mm-hmm. There's a strong emphasis in our report on peer workers and people having access to that type of support, and we're very strong on, as I mentioned earlier, that there's a whole range of things outside of the clinical health system that really matter for people's mental health. So we put big emphasis on peer workers working with people on the types of issues that Ms Bell's indicated.
Yeah. Just a final point on that, sorry. Recognising the time limit. Again, one of the areas of our recommendation is more specific help to GPs through independent assessment and referral process associated with a digital platform. That's very similar to the Victorian Royal Commission recommendation. A difference is that I think the Victorian recommendation has the GP still as being the required gateway through which a consumer can access that, whereas we said there should also be just simply the ability for a consumer who needs help to be able to go to that platform and receive moderated help rather than perhaps relying on Dr. Google or other internet searches to try and gain that information.
Okay. Question from committee members?
Thank you, Chair. Look, I just wanted to follow on that point you made about GP. So in terms of your desire to see more low-intensity support, which I think post-COVID is going to be important because there'll be a lot of loneliness and disconnect and all the rest of it. So do you see GPs as primarily being the starting point for people to access those kind of services? And if you do you have a view on whether the Medicare schedule fees, as they're set up at the moment, properly support GPs to have these longer consultations, that it might take to understand the low intensity mental health needs of their patients. Just by way of background, I guess what I'm saying is I'm getting feedback from GPs who say that the Medicare schedule fees obviously encourage them to do those quick, short, sharp 15-minute consultations when, if somebody's presenting to you with eating disorders or something, you really need to take that 45 minutes to an hour to really properly assess.
Could I perhaps deal with the first part of it and ask
Please.
Dr King to deal with the schedule items? One of the really important things in our report is that it's consumer focused. So it's really about empowering consumers. We appreciate that in certain circumstances where someone is very unwell and they present at an emergency department or they need they need a high level degree of care, that there are issues about whether they're able to manage that care themselves. But we looked at broad issues around anxiety and depression. So there's a whole cohort of people, if they were given the sort of information that they could access themselves, they could do more. And I don't say that in a pejorative way, but
Yes.
they would be empowered to do more about their own mental health. But Dr King, perhaps if you can talk about the schedule items.
Yeah, so thinking of GPs, and we've also received feedback, and I know there was a session yesterday at the Mental Health Victoria conference where one of the panel members said, the PC has sidelined GPs, and with due respect to the speaker, that's not right. Okay. GPs will remain the most common gateway for individuals in primary health care to access a range of relevant medical treatments for mental ill health. That being said, we have recommended some significant changes to the way, to the way that GPs do that. So currently the main tool is through a mental health care plan that allows them to be then referred, for example, to face-to-face psychological therapy. We've suggested that be replaced. And there have been issues in the past about whether the Medicare benefit scheme and the items enable a GP to effectively, cost efficiently, if I can put it that way, put time towards that plan. We've also suggested more online resources to make it easier, quite frankly, for the GP to access the information that they need when dealing with a consumer who comes in with significant mental health issues. Some GPs are great at that, but other GPs, their interests are in other areas, they need more help. I think in general, we haven't gone down to individual. I think there might be one or two, and I'll look at Ros to see if she can clarify that. But in general, we haven't gone down into individual items. More what we're thinking of is change the system around GPs to make it easier for GPs to help the consumers.
Right. Was that their feedback to you, the GPs, that they wanted more online resources, or did you take much feedback from them? We
took feedback from GPs and also from consumers, also from the psychologists and psychiatrists who really are the other side of the mental health treatment plans. There was pushback by the GPs on removing the mental health treatment plan because it is an area where they creating a plan they are remunerated for, and quite reasonably they would be worried that if that was removed and nothing else was in its place, then that would create more disincentive, not improve their ability to work with mental health consumers. That being said, the evidence was pretty clear from the other side of those plans that the plans are really, they're very variable in quality. Some are great, but many are not really fulfilling the function that they're meant to be. They're really little more than a referral.
Can I ask, because I'm sorry, Joe, I don't want to monopolise the time. This is my last one, I promise. But you also focused on young people in particular, which I liked, and you talked about the tertiary education sector. I've got UQ in my area. Part of your recommendations was specific resources on campus and things like this. I actually find my experience is that my Headspace centre locally is the second busiest in Australia, and I think that's a lot of the kids coming from UQ. So I wondered whether, rather than specific resources in each tertiary education, whether you looked at the Headspace model and whether the funding was sufficient, whether the current funding model for Headspace was sufficient to cater for growth that they could perhaps attract out of those tertiary institutions, and we could use that existing facility that's set up for young people rather than trying to get each tertiary institution to institute their own resources.
Yep. So pretty much every university, and I'm almost certain that UQ would be among them,
Yes.
already have on campus.
Yes, I'm sure they do too.
Clinics. Really, our recommendations for tertiary education institutions, specifically, if I can focus on the domestic student ones, is that those universities put in place an overarching strategy for the mental health of their students, and then make sure that the services are there. Now, it may be the case, for example, that UQ would consider that it's better to talk to Headspace, particularly if it's very close to the campus and close to the campus accommodation, and say, well, can we put money in to have Headspace expand to provide more services for our students, and we'll make sure that those students are aware of those services. So our report is quite flexible that way. In a sense, we're not saying to the universities, look, here's the way you must do it. More than happy for the universities to innovate, work with outside organisations. What we can't, or we think is unacceptable, is for the universities, as unfortunately tends to be the case at the moment, really to put mental health of their students to one side.
I like your idea of them contributing to Headspace. That's excellent. All right, thank you, Madam Chair.
Question, Susan?
Thank you, Chair, and thank you. Look, I think each of us could probably spend hours digging into the detail and picking your brains on this. I want to turn to the work you've done on how children with mental illness fall behind in school. And I'm particularly thinking in the context of the bushfires, given my electorate had the biggest fire the world has ever seen from a single ignition point. And so in terms of your recommendations and thinking about what might need to be given even greater priority in the wake of the year of bushfires and COVID and that we've had, around that early intervention with younger children in primary school age and even preschoolers, I'm just wondering which of the recommendations that you've already made, or what additional thoughts would you have about what we should be prioritising?
I'm happy to go.
I will deal with, as you will have noticed, I will deal with part of it, and my colleagues no deal. It's a big report, so we had particular areas where we were interested in. I think one of the most important issues was really assisting teachers in the classroom, because it became very clear to us when we spoke to a lot of people in education and at the coalface that they were facing these issues already. Like they had to deal with in the classroom, and there was an issue about the support services that they could expect. And we also noticed, it's not true everywhere, but there's often a disconnect between the school and its local services. So some places were not even aware. It was interesting, your colleague asked about Headspace. Well, it was true also in the schools. They knew that they had to do something, but they may not have something to refer to. So one of the things that we're quite clear about is trying to support teachers doing this work, but also connecting services better.
And there's really three layers of recommendations that we have, which start off with the support for new parents, then early childhood, and then school-based intervention. One of the diagrams, which I think we provide to you and is also in the overview, I'll call it the bubble diagram, summarises returns and the potential benefits from those. We've emphasised the support for new parents and the school support because, based on the evidence, they can give very good returns and have, in the case of the school support, potentially huge impacts on quality of life of many of Australia's children. We recommend preschool, more support at the preschool level, although the evidence is that it's actually not quite as important as the other two. The other thing I'd mention is that at that school level, the support for teachers, we had quite a large symposium of schools following our draft report, which had a very specific recommendation for schools. We found out that there's lots of really good stuff happening in some schools around Australia. And so you'll notice, again, we've stepped back and said, well, there's no one-size-fits-all solution here for schools. There's lots of good stuff. The schools need much more information about what works, because at the moment feedback from school principals was, look, we just get overwhelmed. We have no idea what's evidence-based, what's not evidence-based. So they need the information. But different schools, I suspect, will take different approaches that best meet the needs of their communities, but it is a key area of reform.
Is there time for me to ask one more?
Yes.
Just on the issue of private health insurance, and I guess I'm really going to the issue of affordability of access to any service. And what I guess I want to play devil's advocate around is just exploring that idea that that the funding is going to come from insurance and life insurance, private health insurance, and what options you might consider are more effective for that low-income access. And I particularly want to pick up on something I can't find now where it sits about people who are unemployed and supporting them with an ability to access appropriate mental health support services. Because I know you had a specific bit around that. I just can't dig it out on the iPad.
Yeah, perhaps if I'll
So
deal with the private health
and
one and then pass over to Julie or Ros for the other part. But just on the private health insurance, I don't think it's an either or. The feedback that we had from the private health insurers and the life insurance companies is that they feel that the current restrictions on their ability to offer services to their members means that they're unable to, in a sense, get in early enough and prevent the deterioration of the relevant consumers. And yes, it's only going to be dealing with those who can afford private health insurance, who are, I don't know if it's still a majority of Australians, but I'm not sure where the numbers are now, but there are many people who can't afford it. But there's still a potential gain there. Now, for those who can't afford it, if I can look either Ros or Julie, would you like to answer the second part? Specifically?
We didn't receive huge evidence to support the idea that there was a lot of people out there unable to afford the care.
You didn't?
We didn't.
Oh, you better come to my electorate office.
I do think it's a two-part answer, though, because one of the things that we did observe is that we had a good look at the social security system, and it's very clunky. And to be honest, we looked at it and thought, well, if you're mentally unwell, how can you navigate this? But there are efforts, you know, to make that easier, which is why we're also, I come back to this point, really strong on peer workers, because sometimes people need some assistance to navigate through it. The reality is, though, that for some people, getting the help they need is going to be challenging. Part of that was a rural and regional issue that, you know, when my colleague spoke before, that was one of the reasons that you won't see the Productivity Commission being prescriptive, because we knew that different things worked in different places. We'd received quite a lot of direct evidence that in some towns, because they're so small and you have parts of your electorate, people didn't want to actually go to the designated mental health area because they didn't want people to know that they were going there. So that was quite a big issue. The other thing is that we did look at social isolation. So there was clearly a cohort of people who were very socially isolated, which will have been made worse by COVID. And then the issue was, well, how can those people access services? And we did have, to be frank, some quite distressing evidence which was given to us at hearings about those social isolation issues. But it's a big, as you've rightly said, it's a big complex area. It doesn't have really fast things that we can do. We can improve some things. If we could help people to participate in their own care more, that would be a service, but we know that some people don't have access to the internet. But we also found, rather surprisingly for me, that libraries played a really important part in people being able to access the internet, and people felt comfortable to go into the internet. So as my colleague said before, we want to have services that people could rely on, that they could actually go into the, into the Google machine, for want of a better word, and the information that they get would be something that would assist them. But it's, as I said, I don't want to gloss over it because it's a big issue and it's got a lot of moving parts.
Yeah, I think just a one-line summary, sorry, because I'm aware of time, is that there are some issues of affordability. So we talked to people who sort of said, look, I can't afford a psychiatrist or a psychologist, they're just way too expensive. For Medicare rebate pays for hardly any of it. But far more, particularly when you start looking at those in-community services and the community support services, it's not that they can't afford them, it's that they don't exist. So, you need to have the services there in the first place.
Or they had funding cycles. I mean, we always talk about this, but funding cycles that were 12 months, and you couldn't really run a business around that. So they'd get people skilled, and in mental health it's really important, the relationship between the care provider and the person. And then that person would have to seek other employment because they didn't have employment certainty. So we said something about the funding cycles.
Thank you.
Great, thank you.
Thank
Yeah,
you.
thank you.
My question, you've mentioned peer workforce a few times, and I think that the peer workforce has expanded quite rapidly in recent times, and they provide a lot of support, advocacy, and, as you mentioned, navigation of services. I'm just wondering about the training and regulation of the peer workforce, and specifically as it relates to the concern around Australians who need access to mental health services, but making sure that they get evidence-based treatment. Would you like to speak to that point?
I know we have a recommendation on Chair on peer workforces and the training, but I'm looking at my Assistant Commissioner here.
If you give me a minute, I'll have a hunt. So we didn't go to the extent of, from memory, of recommending particular training or qualifications for peer workers. We wanted to leave that with essentially providers and consumers to direct what they were needing, rather than put in place arrangements that would truncate or narrow down the range of people that might be available to help.
So just to clarify, you're concerned about people getting access to evidence-based treatment on the one hand, knowing that the peer workforce is expanding. There is no specific recommendation about the regulation and training of the peer workforce.
Chair, would it be possible for us to take something on notice? We do actually have a section of the report where we looked carefully at that, because we have a whole section on skills, and my apologies to the committee being not quite across that. I know we've got a section on that, and we certainly did look at it, and I think we made some recommendations around professionalisation, if I can use that word, for the peer workforce. We also knew there were cultural issues, that not all of practitioners were keen on peer workers, but we also saw the other side, that the direct evidence, and there was evidence around this, that the people who needed the services valued the peer workforce. But if we may come back to the committee on your question.
Yes, absolutely. I'm going to hand over to...
Thanks, Fiona, and thank you all for your evidence this morning. I just have two questions. You've talked a lot about your recommendations where, GPs are the primary focus and that there should be a lot more online opportunities for people to access. I'm concerned that there should be a third space as well, because some people with mental health, online is not the space for them. Some people either do not have the resources to be able to go online, however fantastic the libraries are, and they're great in my part of the world, but however good they are, and the nature of their particular issue is so acute that they fall through society's cracks. So, you know, they can't comply with job active requirements. They become those very sad homeless people who live under the bridge. Did your report suggest a third option that is currently lacking in the system to support these people before they get so mentally ill that bringing them back is very difficult, both for them and for the people who love them?
So,
I've got two parts to that. The first one, the housing issue, there is a section in our report where we did actually look. I mean, as I'm sure you know, the mental illness and housing is actually a really complex space. It was clear to us that community organisations played a really important role in that outreach and supporting people with mental health conditions. The other issue is that we wouldn't want to overstate online. When we talk about online, we're really talking about a large cohort of people with anxiety and depression. We were not really talking, although there is some good evidence that even for people with quite serious mental unwellness, that the online services can help. But my answer really to what you've asked is, well, we put a big emphasis on community support and care for people in the community, and also supporting the carers. That was a really important part of this because, you know, it was the carers that were always left with, well, I can't get my child, and we heard quite, as I'm sure you will, quite distressing evidence, can't get my child into hospital, but I don't know what care I can get for them. So I guess I wouldn't have put it as a third way. I would have said all of these things need to work together at the same time.
I think if I can just back that up, you can think of there, and this is how we characterise it, you can think of there as being two gaps in the broader health system for people with mental ill health at the moment. One is down at low intensity, and the many people with mild anxiety and depression or depression who at the moment the only gateway is a GP, and that often leads to medication. The only other gateway they have is Dr. Google at the moment, and so we're trying to fill that gap and provide more support. Then you've got the missing middle gap, which is the people with more severe mental ill health who need a lot more support to be able to recover in community. And that includes things such as, just on the health side, having the resources there for proper planning and proper coordination of the services that they need. It includes the community level supports so that when, for example, the condition starts to deteriorate, and we heard from many people who said, when my condition deteriorates, there's nothing for me except the emergency department. So filling that gap and having those community level services, step up, step down type facilities, so that individuals who feel their mental health is deteriorating are able to access those services on a short-term basis and then continue their recovery in community. So we've tried to design a set of recommendations that has flexibility between non-health and health services, recognising that for people particularly who have the more acute mental ill health, their needs are going to change over time. And you need a system that is able to coordinate and be flexible enough so that the services move as their needs move, and hopefully keep them away from the emergency departments. That will sometimes be necessary.
I'm just conscious of time because we have gone over. I think we have to end the session here, but I would like to ask, if you don't mind, as the inquiry progresses, and as we explore more issues, we might like to have you back, if that's okay. So I just want to thank you for your attendance here today. The committee secretariat will be in touch with you in relation to some of the matters that arose from today's hearing, and you'll be sent a copy of the transcript of your evidence when it comes available, and you'll have the opportunity to request corrections to the transcription errors as well. So thank you very, very much for your time. Thank you. Thank you.
Very much.
So we have representatives from the Department of Health appearing today. For the benefit of Hansard, could you please state your full name and the capacity in which you appear before the committee?
Thank you. Tanya Rishnu, Deputy Secretary, Primary and Community Care Group for the Department of Health.
And Mark Rodham, First Assistant Secretary, Mental Health Division, Department of Health.
Thank you. As Chair, I need to remind you that although the committee does not require you to give evidence under oath, the hearings are legal proceedings of the Parliament and warrant the same respect as proceedings of the House. The giving of false or misleading evidence is a serious matter that may be regarded as contempt of Parliament. I'd like to invite you to make a brief opening statement before we proceed to questions. So I'll hand it over to you.
Thank you very much. We didn't propose to make an opening statement today, but I'll leave it for the committee to ask us questions to maximise your time.
Okay. One of the questions that we have in relation to the Productivity Commission's report is the lack of data on outcomes. While the submission to the committee included a comprehensive list of departmental expenditure on mental health, there were no valuations of effectivity or outcomes for funded programs. So I'm just wondering whose responsibility it is to measure outcomes for recipients of services and how this lack of outcomes data will be addressed going forward.
So I'll start and my colleague Mr Rodham will step in as well. Obviously there's a range of programs that the Commonwealth funds and a range of programs that state governments fund. We do aim to measure outcomes, but as the committee will be aware, measuring outcomes in mental health over the long term and particularly with people's episodic care is not easy. There's a range of different evaluations of programs that have either been done or are underway. And in particular, in the past, under the 5th National Mental Health Plan, there's quite a broad outcomes framework and performance indicators that were included in that. That still continues to be kind of a key pursuit, both at the Commonwealth and the state level.
I could perhaps mention some of the evaluations underway. So we've just commenced an evaluation of the Better Access medical benefits schedule system. We're in the early stages of evaluation of Headspace, which would be the first one done since about 2015. And obviously, given the significant expansion of the network during that time, that's particularly important. Recently completed an evaluation of the early psychosis youth services run by Origin. And a lot of strategies, I guess, and frameworks underway which will help those evaluations as well, so including of our digital program, a mental health workforce strategy underway and a range of others. So certainly on notice, Chair, we could provide a list of those evaluations underway or recently completed if that would help the committee.
That would be useful. One of the issues that has come up is the role of the peer workforce. The question that was asked earlier was in relation to the training and regulation of the peer workforce and the concern around evidence-based recommendations for treatment options for people. I just wondered if you had a view on that.
I can take that, yeah. Look, I think the peer workforce is an incredibly important area and a growing area, obviously, of the mental health workforce. I think the thing is that it's important they're part of a team, part of a multidisciplinary team, and have the appropriate supervision and are dealing with the sorts of mental health issues that are appropriate for their experience and for their qualifications. So certainly we don't envisage a peer workforce acting outside of that system, but is trained working as part of those multidisciplinary teams and providing support to those experiencing mental health challenges through those means.
When you say supervision, what kind of supervision would you be envisaging for peer support?
I think working in teams with mental health nurses, with psychologists, with psychiatrists where appropriate, they're an important part of the mental health workforce, but it's important they work in with other parts of the mental health workforce.
Would you go so far to say that working in isolation as a peer support workforce participant is potentially dangerous to patients?
It would depend on the setting, but yes, if in the wrong setting, yes, I think that's potentially the case.
Okay. My next question, sorry if I may, just in relation to workforce capacity and the issue around psychologists, particularly, or their lack of in a number of registered health professionals that work in the area of mental health. What sort of strategies or ways that we can incentivise, do you think, people to join the mental health workforce so that we can expand the mental health workforce to service the needs of the growing needs of Australians, particularly since the bushfires and COVID-19?
So we're very aware of the Productivity Commission's report, obviously the Suicide Prevention Advisor's report, and the Royal Commission that Victoria has just concluded, and looking at particularly both the need and availability of workforce, and the workforce across the span of professions, ranging, as we've started with, in terms of peer workforce, mental health nurses, mental health occupational therapists, right through to psychologists, psychiatrists, GPs, obviously a key part of that. We're in the process of developing a workforce strategy and working with an expert reference group in developing that workforce strategy to look at the pipeline. Obviously, they will have a range of views and recommendations about both attraction but also professionalisation and increasing the availability and access to a qualified workforce. In terms of psychologists in particular, once again, working with the tertiary sector around attraction and affordability in terms of completing qualifications is going to be a critical part of that.
The only other thing I'd add is with later this year agreeing to seeking to agree a national agreement with states and territories on mental health and suicide prevention, placements for psychologists and psychiatrists for that matter are a really important issue to increase that availability. So that's really an area where I think the two levels of government need to work together, and that's what we would aim to do through that agreement.
And when is the task force due to provide recommendations to the government on this issue?
So they've provided an initial set of recommendations to government. The strategy continues under development this year. Over the coming months, we'll be starting to engage with states and territories around the strategy. So later this year, the strategy will be finalised, and then I think we need to look at the issue of implementation plans to give effect to that.
Given the diversity of professions that make up the mental health workforce, be that mental health nurses, mental health occupational therapists, mental health psychologists, psychiatrists, and others, do you have a view in terms of which professions should be treating various mental health presentations, ranging from very mild issues through to quite severe, profound presentations that are very complex to treat?
So I don't think, I wouldn't want to profess a clinical view. Obviously, from a departmental policy perspective, we would take clinicians' advice in terms of treatment for particular conditions and particular presentations. Once again, in terms of the evidence that we've seen and the work that we do with various professions, the need for psychiatrists and psychologists, particularly in the more severe end, in the acute end, but the need for multidisciplinary care and a range of pathways and treatment professionals in actually treating the person presenting to them is absolutely critical, and the evidence bears that out. At the same time, looking at the range of the stepped care model, which is one that's been accepted by professionals and is evidence-based, and one that informs our investment through primary health networks and across the spectrum, looking at more low-intensity interventions, looking at appropriate care, appropriate clinical care, but also self-help resources for people to be able to find the pathways they need is critical. And that's why we've been working with PHNs and all of the various professional groups to look at where do people get the right care at the right time in the right context.
Yeah, and a particularly important part of that work with the PHNs and potentially with GPs in future is the work on an initial assessment and referral tools. So we've used that in the Head to Help clinics that have been rolled out in Victoria last year, and in the development of the adult mental health centres as well. So essentially people are assessed according to that tool and then triage the appropriate care from there. So, and I know there are various versions of those sorts of tools around, but that's a lot of work we've been undertaking at the
I just
Commonwealth.
have one more question before I pass it over. Given that the number of psychiatrists and psychologists is increasingly moving into the private sector, in that they're working in the private, privately as opposed to in the public system, how do we ensure that individually, privately practicing psychologists and psychiatrists have access to the infrastructure that the federal government is investing in to ensure that they're benefiting from this as they're practicing and seeing, the large numbers of patients across Australia through the MBS?
So in Australia, we are fortunate to have a mixed model of public and private investment in terms of healthcare, and particularly mental health care. And we try and use, you mentioned earlier, I know with the Productivity Commission, the role of private health insurance and the attraction of particular products there, the role of MBS in terms of funding and rebates to patients for particular services, right through to publicly funded services in the community, and the use of particularly psychologists and psychiatrists in the public system. It's where Mr. Rodham mentioned earlier, we're working with the states and territories around how do you actually provide more attractive interactions and connectivity in the system between the private and the public system, and looking at how do you make sure that particularly professionals can work across those systems at the appropriate levels and in the appropriate circumstances. So kind of at the broad level, absolutely we're looking at how do you make the best use of the workforce that we currently have, and the right ways of incentivising and working with them to make sure that where they need to work in the public system, they have access to that.
I think what I'm getting to is the fact that, particularly in recent times, we've gone from, say, 10 to 20 sessions in the MBS, and that's probably incentivised people to move into the private sector if they weren't already. That's expanding. The federal government invests a lot of money into infrastructure for mental health, head to health, etc. And a lot of those resources are very good, but I think there may be, and you might know better than I do, but there may be a lack of a connection between those practicing in the private space and the infrastructure of resources that are invested into mental health for mental health practitioners.
I think that is a fair comment, Chair. That's exactly the sort of issue we're looking at in the evaluation of better access, and that system, that MBS system, to see how those practitioners can link together better. There's a whole range of things we'll look to in that evaluation, so we're looking forward to the results of that at the end of this year or early next.
Fantastic. I'm going to hand it up to you. Susan, sorry.
Thank you.
Thanks.
Of course, I have a million questions, but I'm going to confine it to two. One is, in your submission, you talk about the role of the department, and I think as a committee, we're still working out exactly how we fit in the process, because it looks like you're reviewing all the things that we're reviewing, but you're doing it with much greater resources, I suspect, than we are. And I'm just wondering if you can articulate where your advice, recommendations, or how you're bringing together the Victorian Royal Commission, all the different reports, and how that's feeding into a government decision-making process from your perspective, just to help us understand how we might be most effective.
Yes, certainly. So you've obviously had the Productivity Commission speak with you this morning. That was the first major report handed down of what we see as the three major reports they're influencing our thinking at the moment. The second, the advice from the National Suicide Prevention Advisor, and now we have the Victorian Royal Commission. And I think the important thing for the committee's knowledge is, I'm not sure if the Productivity Commission went into this, but all three of those authors of those reports were talking to each other during the development of the reports. So I think you can see, when you read the Victorian Royal Commission, a fair bit of consistency with the Productivity Commission report, obviously coming from the perspective of one state. So from our point of view, we spoke with the Productivity Commission as their report went along, and we're involved with them. Same with Ms Morgan in her suicide prevention advice, and we were also meeting regularly and made a submission to the Victorian Royal Commission. So now that we have the advice from those, the Prime Minister, I think, was clear when he released the Productivity Commission report on the 16th of November that there would be a response to, at that time, just the Productivity Commission report in the context the May budget and saw, and announced the creation of the National Mental Health and Suicide Prevention Agreement. Since that time, in late December, the National Cabinet Reform Council, which is probably closest to the old COAG annual meeting that used to happen, jointly committed to developing that agreement by November. And so we are working towards a budget package in May and a response to the Productivity Commission in May, working towards that national agreement being negotiated by November. And also, prior to that national agreement, it's been announced that we're working with Victoria on a bilateral agreement, which we are hoping to conclude over the next couple of months, and that will help give impetus to the national agreement. So that's how we see it all coming together, and really probably a once-in-a-generation chance for reform at the moment and to create a better mental health and suicide prevention system, and that's what we're all very focused on.
And if I could just add to that, I think we're taking all of those reviews, and as my colleague has said, they are actually quite consistent in the direction, the connectivity that's needed in the system, the roles and better clarifying roles of Commonwealth and state governments in this. I wouldn't want to leave the committee with the suggestion that we're reviewing that. We're pulling together that evidence. The PC has done a very comprehensive job. The National Suicide and Prevention Advisor has done a very comprehensive job. We have good evidence from the Australian Institute of Health and Welfare. We have good evidence in terms of the Victorian Royal Commission. So we're not proposing to review, we're actually taking the benefits of that evidence and that review and looking at what is the role of the Commonwealth, how do we work better with the states and territories, how do we work better with the professions and the consumers and the carers to try and implement an integrated system.
Thank you. I won't ask you the question, but it does make me question how our role will, like you are doing a very comprehensive job, and I guess, Chair, I just question how our interim report and will actually be useful as part of the process. So I just raised that. The second question I had is just around workforce, picking up on some of the questions the Chair's asked and you've started to explore, and this whole idea of multidisciplinary approach. Have you got clear views on the roles that each different discipline plays? For instance, there's been mention of psychologists and psychiatrists and some mention of peer workers and the need for adequate training and the like there. But I think also of counsellors, psychotherapists. I just wonder if there is a view from the department about what that multidisciplinary mix is that you'd like to see going forward.
Well, just to perhaps start by reiterating what Ms Risnew said earlier, that's really according to the stepped care framework that's widely agreed. So as you move more from prevention to mild to moderate mental illness through to severe and acute, then you gradually get more. You go along perhaps from counselling and peer workforce, etc., through to clinical psychology and then psychiatry as you go along. So we don't, as a department, seek to judge on clinical decisions, I guess, but we have that stepped care framework. We've put a lot of resourcing into developing an initial assessment and referral tool that services that are funded by the Commonwealth can use to assist with that. And it's just ensuring that you have those services, those professionals working together so that the person gets the service at the appropriate level that they need.
And are you considering what public funding, MBS funding, might be required additionally to ensure access to those different stepped services?
Yes, well, there's a couple of things there, I guess. We have the 8 adult mental health centres under development around the country at the moment, so that's really where we're focused on using that model. And that may have a mix of MBS and salaried staff there. And Headspace at the moment, for example, uses a mixture of salaried and MBS funded staff as well. So it really depends on the setting, I guess.
Thank you.
So I wouldn't want to suggest that MBS is the only funding mechanism for mental health services, and we have used a range of different funding mechanisms, including commissioning and grants through the PHN, to ensure that you can provide services particularly to lower income, lower SES, lower intensity services that are actually available free to people.
And the primary health networks are really important there in terms of providing free services to people who may not be able to afford.
Thank you. Thanks, Chair.
Just a question.
Question. Thank you. I'll be very quick because of time. We just heard from the Productivity Commission about their concerns around a gap for new parents and particularly for young kids as well in terms of mental health education and intervening early. I know I've gone through your submission. I see, we're very focused on youth and Headspace and 16 to 24-year-olds. Have we got any funding or any programs that specifically relate to younger than 16 or that goes into schools, etc.?
Yes, so Headspace starts at the age of 12, so it's probably the 0 to 12 age group that we don't have anything specifically funded from the Commonwealth beyond programs like Beyond Blue's BU program, which works with educators in schools and some other things. The Mental Health Commission I know is on after us, and they're developing at the moment a child mental health strategy. So they may be able to, it's probably more appropriate for them to tell you more about that, but it is really an area of focus for us. And again, because of the role of the states in that age group more broadly, and in schools, I'd see that as issues we really want to progress this year as part of the National Mental Health and Suicide Prevention
It is a
Agreement.
gap from the departments and the federal government's point of view. We don't have we're not doing a lot in that 0 to 12 space at the moment.
Well, we do. We certainly.
It's not a criticism.
No.
We're here to identify gaps.
Yeah,
so we may as well.
Yeah, that's right. Look, there are things that both the states and us fund. I would put it that way. I wouldn't say it's either level of government is completely absent from that age group. But clearly, the point of the strategy that the Mental Health Commission can talk about is to create a better system in that regard.
Yeah, and it's obviously the gap that was identified by the Productivity
Yeah,
Commission.
look, and I certainly view it as a gap. So perhaps if you can take it on notice as well, if there's anything else that we're doing in that space, if you could feed it in writing, would be helpful.
And we haven't mentioned the perinatal funding that we've done. So there's certainly a bit, particularly with new parents and postpartum depression, that's quite well resourced, and we've done a lot of work there. But as my colleague said, I think we can do more in particularly early childhood. The other point to make there is obviously the role of states and territories, particularly once we're reaching into schools and looking at what we can do with states and territories around the services there.
And then point 60 of your submission about the Headspace review. So is that going to include the funding? Does that include the funding model, a review of?
It's a comprehensive review of Headspace. So it's the first one that's been done in 5 or 6 years. So, yes.
Okay, because I have a view that the Headspace funding model as it stands doesn't adequately cater for Headspace busy Headspace facilities to gear up. It provides a base level, and then we're kind of just topping up ad hoc. Does the department have an initial view on that, or are you really just going to see what comes out of the review?
So the government's announced quite a significant investment in reducing Headspace wait times.
Yes.
And I think there's a range of reasons why those wait times exist. Sometimes they don't have anywhere to refer people onto who maybe have a level of acuity in their condition that goes beyond the sorts of services that Headspace might normally provide and not able to refer into what might traditionally be the state system. There could be I heard you talk before about your particular situation in your electorate with having a university there. I think there are different reasons for that, but it's certainly a focus to get the quality of data from Headspace and working with Headspace National on the wait times and addressing them.
Will you take on notice, providing the committee any further work that the department's done on alternative funding models for Headspace? Is that
Certainly,
possible?
yes.
Thank you.
Take that.
All right. Yep, that's it.
Deputy Chair.
Thank you for appearing before us today. I'm mindful that time is tight, but I just have a general question you might like to get back to me on. Following on from Susan's question, we have the PC report, the Victorian Royal Commission, the advice from Christine Morgan, who is here, and you mentioned AIHW. For the purpose of our committee, what information do you think that we don't have that we need in terms of informing our work? So that's a general question that you may feel free to come back to me on. The actual question I had was when we just heard from the Productivity Commission, I was asking about, what could be done now or, in terms of starting points. And they said the first thing we need is this agreement between the jurisdictions around responsibility and funding. So we've moved from COAG to now, and you referred to the National Cabinet Reform Council, a bilateral agreement with Victoria. What do you think is the mechanism for that at this point in time?
So National Cabinet and all First Ministers have agreed that the first priority for the Health Reform Committee is to actually pull together a national partnership agreement on mental health. and the timeframe for that is November this year. That is an ambitious timeframe in terms of Commonwealth state negotiations and looking at how do we better clarify roles and responsibilities, how do we look at where do we need a more integrated system, what is the role definition for all parties, and how do we work with jurisdictional flexibility but with the ultimate aim of improving mental health across the country. There's obviously a high level of commitment. That was all premiers and the Prime Minister committing to that. All health ministers and mental health ministers across states and territories in the Commonwealth have committed to that. And we're starting to do that work around better teasing out, taking the Productivity Commission report, taking Ms Morgan's report and looking at how do we first target that national partnership agreement around mental health. It'll be the first one of its kind.
In terms of the mechanism, though, which I might have, there is a Health National Reform Council under that national cabinet structure that is tasked with reaching agreement. So that's the mechanism under the national cabinet structure in which it will happen.
Okay, and I just had a general question. Given we're in the increasing demand and distress that we've seen and heard from so many individuals and organisations and advocacy groups. Just the Chair and I were talking about it, bushfires, COVID, floods. Do you see particularly, say, an increase in the necessity for funding for particular services, telehealth or others, given this surge in demand, complexity and distress that we've seen?
So one of the things I think we've learnt particularly over the last 18 months is we've put in place a range of services and a range of responses, particularly to crisis points, and looking at, in many ways, what's the mental health temperature of the country and particular areas. I think it's clear that telehealth, and particularly telehealth for mental health services, has been taken up at a huge rate. We've seen, the MBS additional 20, additional 10 services taken up. We've seen the investment that we made through the bushfires starting to kind of reach into communities at that level, and certainly working much more closely with states and territories in that crisis point to look at integrated services. We then had COVID come in over the top. So some of those initiatives that we started to seed fund in communities through PHNs, like the community grants for actually community resilience and rebuilding, had to change tack in the middle of COVID, because the kind of community gatherings, and this in part goes to the question I think that you've asked about where the role of the committee, looking at how do we reduce stigma, particularly in rural and regional communities. How do we actually make sure that people are accessing the services that are already there, let alone how do we design services that better cater to people who would not necessarily feel comfortable in talking about mental health in that context or identifying as someone who is struggling. How do we better target those kind of services is something that we are continuing to learn through the range of different investments that we made, particularly last year, and continue to make.
Okay. I'll make mine a really short question. Do you think that there are enough GP services available Australia-wide? I know in communities like mine, I know of at least 4 or 5 GPs who are about to retire. When they retire, their particular practices will no longer, that sort of practice with that continuous care won't be available. So you'll get a medical centre where you see a different doctor every time. We've heard lots of evidence both today and in other spaces about the critical nature of GPs to either be the primary caregiver to someone who has a mental health concern, or to refer them onto other areas. It just concerns me that there's not enough of them, because they do everything from a broken arm to immunisations, and with the pandemic and everything else that our communities have got, they are the people who are dealing with this sort of stuff. They're dealing with the carers, they're dealing with everybody else. So do we have enough?
So absolutely recognise GPs and primary care as often the key doorway for people, particularly with mental health, but more broadly with primary care. I think at the heart of your question, I would say there are a lot of GPs across the country. The question is maldistribution. And so where are those GPs located as opposed to number of GPs? And once again, I think it's clear that telehealth over the course of COVID has actually opened up access in a different way. We're still working, particularly in rural areas where you've often had lifelong GPs coming to the end of their particular careers, and how do you actually step in and make it attractive for GPs to go into rural and regional communities? We're trialling a range of innovative models to look at how do you actually create an attractive GP practice in regional communities linked with potentially state hospitals, different funding mechanisms. Is MBS enough to actually attract people to those areas and provide those services? So there's a range of different innovative trials underway. But certainly recognise, kind of at the heart of your question about regional and rural communities and access to GP care. As I say, I think it's not necessarily the number of GPs, but where they're distributed, and how do we make sure that people in regional and rural Australia and remote Australia get access to the best quality care they can.
While I am particularly sympathetic to people in regional remote communities, my community is 30 kilometres from Sydney CBD. I'm in southwest Sydney. We have a very fast-moving, growing population, as the chair is definitely aware of. It is not just regional communities that are finding. My own GP is about to retire this year, but it can be 2 weeks before you get an appointment with him. And I can tell you that is not an unusual situation in my community. If you have a mental health issue that is escalating, 2 weeks for an appointment to an overworked GP is the reason why quite often they end up in emergency hospital presentations, which is not the best option. If you could get it 2 weeks ago and rearrange their medication, or whatever the case may be. So, I'm concerned about the whole of the situation, that there is just not enough support and enough GPs. Yeah. But thank you.
Thank you. Thanks for your attendance here today. The Committee Secretariat will be in touch with you in relation to any matters arising out of today's hearing, and you'll be sent a copy of the transcript of your evidence when it becomes available, and you will have an opportunity to request corrections to transcription errors. Thank you so much for your time. Thank you. Thank you. Very gorgeous. Well, that's You're going to go. Okay. Thank you. Yes. No. Yes, yeah. Hello. Hi. Okay. Well, we have representatives from the National Mental Health Commission here today. For the benefit of the Hansard, could you please state your full name and the capacity in which you appear before the committee?
Good morning. Christine Morgan, CEO of the National Mental Health Commission.
And good morning, Lyndall Soper, Deputy CEO, National Mental Health Commission.
Thank you. I remind you that although the committee does not require you to give evidence under oath, the hearings are legal proceedings of the Parliament and warrant the same respect as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of Parliament. Would you like to make a brief opening statement before we proceed to questions and discussion?
Thank you, Chair. Probably not a formal statement, but just some opening remarks.
Yes.
Listening to what has been discussed to date, it is clear that the realm or the range of mental health reform in Australia at the moment is being informed by a number of reports, the consequences of a number of lines of inquiry, and I think a very pertinent question is how do those come together? How are they consistent or inconsistent? And to what extent should they all be weighed together to try to take it forward? To that end, the Commission has undertaken a review of each of those reports, and each of those reports specifically I refer to the Productivity Commission report, the most recently Victorian Royal Commission report, but time has been of the essence with that one, so I can't purport to have read the whole of that report. Clearly the suicide prevention advice, and also the work that the Commission has been doing for the Federal Health Minister around Vision 2030, which has been an extensive project which has really been focusing in on what would it look like, and we've learned what would the experience be like if it was all going well. So if we had an optimum system, and I think that's an interesting point, it's not just what would it look like in terms of the pieces and how they fit together, it is very much for mental health what is the experience of the consumer or the service provider within that system. And that was a clear learning we've had out of doing the Vision 2030. In doing that analysis or that review, we have been able to identify what we regard as being 6 key themes that we believe bring together and have touch points with each of those reports. They're the common areas, if you like. And in order to try and group them in a way that is consistent, I'll take that view of what I've just said from Vision 2030, which is that a well-functioning system is a good experience for somebody. It is, if you like, the equivalent. We have a very strong universal health system. If we look at what that means for mental health, a universal mental health system, I think I would describe it as being accessible, navigatable, evidence-based care in sufficient dosages when I need it, where I need it, and in a way I can afford it. And that would be effectively it. And the experiential components from a Vision 2030 perspective is it needs to be accessible, it needs to be coordinated, it needs to be integrated, and it needs to be long-term, not just episodic. So the 6 themes that we have identified can be categorised into 3 components of what we think creates a healthy experience. Healthy communities, because there is clear evidence that when it comes to addressing mental health, we do it as individuals within community settings. So healthy communities, healthy individuals, and a healthy system. Under healthy communities, we say the 2 key ones that are drawn from each of those reports is the importance of prevention and early intervention, and most specifically workforce capacity, workforce capability, workforce and workplaces. When you're looking for healthy communities, you're looking at the social context of mental health and mental ill health presentations, and you are predominantly looking at how can we keep people mentally well. And there is a strong emphasis in each of those reports on the importance of moving away from how much are we spending on mental illness to how much are we investing in mental health and well-being. When looking at healthy individuals and what we can be doing in terms of supporting people to have a healthy contributing life, you really are starting to look at what are you needing, what are the key thematic areas when you're looking at delivering mental health services. There are 2 very strong ones that come through from each of those reports. Firstly, the need for integration and coordination, and secondly, the criticality of lived experience, essentially shaping and informing not only the conceptualisation of those services, but also the design of them and the delivery of them. And thirdly, when you're looking at a healthy system, one that is consumer-led, one that is accessible, and one that is compassionate, what you're really needing to look at there thematically is accessibility. And accessibility itself breaks down into a number of issues, including geographic and, most importantly, I think for Australians in 2021, affordability. And the second key issue there is that it must be driven by outcomes. So not looking at how is the system necessarily being used in terms of numbers, but is it achieving the outcomes that are needed? They would form the key themes that we have seen linking and informing each of those reports and then the reform agenda going forward. In terms then of, in that very informed agenda and the work that we've heard from the department and others is being done to deliver responses to that, in particular for the role of this committee, I think what has been revealed, if you like, by those reports is opportunities for further investigation in deeper granularity to really bring us to targeted solutions. And in the submission from the Commission, we would regard 3 areas of being of high priority, and then 3 areas of high priority, a 4th area which relates to implementation I'll talk to, and then another 5, when I say subsidiary, I don't mean of less importance, but I think they have good touch points with the terms of reference of the committee. The 3 that we believe really compellingly need further investigation, further granularity. Firstly, workforce. We've heard from the department that they are doing a workforce development strategy, and we're certainly participating with them in that. In terms, though, of workforce needs for Australia, there is a chasm, there is a gap between need and capacity at the moment to deliver, and that is widening. So we believe that under workforce, we really do need to be looking at what are the disciplines engaged in a mental health workforce, what are the roles and responsibilities, what are the core competencies that need to be required in the standards, and what are we doing about the pipeline. And I think that needs further investigation. Secondly, one of the key barriers to accessing the system for people getting in as early as they can is help seeking. And one of the significant barriers to help seeking is the reality of stigma. And stigma, whilst it has been somewhat improved through the experience of 2020, when I think the reality of mental ill health was experienced by many more Australians than previously before and has been somewhat normalised. If you look at stigma through the lens of shame or self-stigma, social stigma, which is attitudes, and then thirdly, structural stigma. What are those things about our policies and social organisation that result in negative consequences for people when they seek help or are treated for mental ill health? That is a very strong and existing situation in Australia. The Commission has been tasked with doing a stigma and discrimination reduction strategy. One of the areas that really requires deep investigation is the reality of structural stigma. We hear many anecdotes of what that may be, but in terms of it... That's right.
Yeah, so we'll reconvene. Apologies, we have to go into the chamber.
Absolutely. We will wait.
We'll wait for you.
Okay,
much.
sorry, where you were.
Yes, so thank you. So I think
Yeah.
what I was addressing was the reality of structural stigma, and whilst we have a relatively strong evidence base that will help inform us around self-stigma and social stigma, the actual reality of structural stigma in Australia we can conceptually understand, but I think does need a much more granular analysis, and it would be of benefit some further investigation into the reality of that. That would assist as we develop the strategy to be able to have quite targeted responses in terms of areas we need to look at. The Productivity Commission mentioned the necessity to engage in the areas of justice, in the areas of finance and insurance. I think they are key ones. But there are other settings as well where there is structural and other stigma. So I think being able to investigate that would be a very real benefit as we do the reductions strategy, and that strategy is due to be delivered by the end of 2022. Thirdly, the third area that I think lends itself to a deeper analysis is around the issue of accessibility through the lens of affordability for services. And we have heard presented already the fact that there are a number of different funding mechanisms that are used, predominantly MBS rebating, which is a rebate system which in and of itself does not really have direct linkage to quality of services, measurement of outcomes, and probably one of the most challenging realities for people in Australia is the significant gap payment that is associated with any MBS rebate. I don't believe that's a simplistic answer to that of just changing the payments. I think it is much deeper analysis is required. So that is certainly affects affordability. Other services are done through grants that are commissioned, as we heard, through the PHNs, block funding, etc. In order to truly achieve a universal mental health system where people can access the care they need, this issue of affordability is a key one. And to truly analyse it, I think it takes quite a deep analysis to say, what are those components of what we are trying to achieve? So what are we trying to achieve in terms of treatment, and then how do we actually link the funding mechanisms to deliver that? To give an example of that through an MBS framework, one of the core requirements that all of the reports call for and is broadly recognised is the need for a multidisciplinary workforce. It would be a significant exception to the rule that somebody would have one professional being able to deliver all that they needed in terms of effective outcomes for mental ill health. The MBS rebate system, whilst it will rebate different disciplines, and whilst it will rebate where there has been case conferencing, that is purely at the election of those professions who may be claiming those rebates. Multidisciplinary approaches, coordinated, integrated approaches, shouldn't be optional. They actually need to be a core component of how services are delivered. Unless you have a funding mechanism which requires that, you are not really matching your funding mechanism to what fundamentally you're trying to do in terms of your service delivery. That is but one example. So I think the issue of funding and funding mechanisms is not one that is going to be solved just with a good think tank. I think it does need a very deep analysis, and it will need a very phased approach with any changes that are done, but I think it is calling out for it. They're the three key areas of investigation. A fourth area that we have highlighted in our submission that is very important is around the question of implementation. And I think it's a well-known maxim that you can have very well-developed theories, processes, strategies, etc. They are only as good as the implementation of them. So as we go forward in a mental health reform agenda, what are the appropriate implementation structures that need to be there and need to be considered? We certainly will be proposing that that should be included in the national agreement between the states and the Commonwealth, states, territories and Commonwealth. But I think it is something we need to put on the table. What are those mechanisms that are needed, and how do we ensure that the implementation process is recognised, resourced, and reports, and that there are measurable consequences if things are not being implemented. So they're the key areas. The other 5 that I will briefly mention that have again emerged from all of the reports, and I think do touch upon the terms of reference of the committee, is what needs to be done in the areas of prevention and early intervention. Reference has been made to the category of 0 to 12-year-olds. That is so. Prevention, early intervention really is about how do we holistically prevent, and early intervention is early in life, early in illness, early in episode. All of those key touch points. Secondly, the importance of workplaces. So if you look at moving to a system where points of access are provided where people live, learn and work, there's an increased recognition that workplaces reach a very large component of the community. And that would be not just those who are in those workplaces, but also their families. So it's a very significant touch point. Thirdly, the need for integration and coordination across the system, which I don't think is as simple as pointing a role of a coordinator. I think it needs a systemic approach to it. Fourthly, and I've mentioned this in the key themes, the role of lived experience and how you translate that not only into peer workforce participation, but actually how you conceptualise, design and deliver services, and what it actually means in terms of longevity of services. And then finally, what do we need in terms of an outcomes framework and what actually is needed in those spaces. So I probably would leave it there, but that is remarks to try and bring together the substance of our submission.
Thank you. That's very comprehensive. I might start off with some questions, if that's okay. I have so many questions, but I'll try and... Given that people, since COVID and the bushfires, given that so many people reached out for help for the first time, and given and knowing that we have a workforce capacity issue, which is widening, and your recommendations in terms of multidisciplinary teams and the issues around GPs being the gateway to the MBS, what do you think we can do to incentivise, firstly, what do you think we can do to incentivise clinicians, particularly as more and more clinicians move into private practice, to encourage more disciplinary teams, be that in GP practices or elsewhere? And in terms of the mental health climate of the country, what do you think the potential long-term impacts are on the mental health of Australians who have reached out for the first time since bushfires and COVID?
Taking those two, so the first question, if I understand it, is effectively accepting, as I think I'm hearing, that a multidisciplinary approach is needed, and we need to actually bring in as appropriate as many disciplines as can come together to provide that workforce. How best to incentivise that? It is challenging because, as I say, under the current system, there's not a lot of mechanisms within the MBS rebated, particularly. So if you're dealing with those in the private sector, and the reality in 2021 is that most of the workforce is sitting in the private sector, then MBS is really your touch point with that. Under current MBS arrangements, there is, as I say, not an ability to actually mandate that and bring it together. We explored it in considerable depth when we were looking at the MBS item number for eating disorders, which absolutely requires a bringing together of your general health, your psychological health and your nutritional health. And there is, because it is a rebating system, it cannot actually drive behaviour. It can reward you when you do something and you submit for a rebate, but it can't actually require it. So absent that in it, I think probably the most effective way, and this is aspirational, but the most effective way you could drive clinicians realising the importance of multidisciplinary approaches and what it could actually mean for somebody who is trying to manage their ill health or their illness is to actually bring in an incentive for a higher rebate if they will involve the consumer or the consumer and carer in that session or in that rebate. So, for instance, if you could ensure that whether it's a psychologist, a psychiatrist, or anyone else who's recognised at the moment under the Better Access regime, that there could be a higher rebate if a consumer was brought into a case conference or whatever, I think you would be then incentivising it. Now, the benefit of bringing a consumer into that kind of environment is that a consumer can best identify what they may be needing in terms of their treatment. So, for instance, they may be, and we use this example in our submission, you might have somebody who needs a psychiatrist for medication, you might need a psychologist for psychotherapeutic therapies, and you may need an occupational therapist to help in your functionality in your social environment, just to use an example. And so I think a consumer, and potentially a consumer and their carer, can best work on that. So that is but one idea, but I think it is a very challenging question that doesn't have a ready answer to it, to how do we incentivise people.
So just to clarify, multidisciplinary teams don't have to be necessarily a collective as such, but they need to, and I think this is just to the definition, they just need to be collaborating and conducting case conferences. And ideally, those case conferences would include the consumer or patient in the case conferences to promote that multidisciplinary
That's correct, and I think that one of the, in order to maximise the reach and efficiency of our workforces, it is important that each of the disciplines works to what we would call top of scope. So if you're looking at that example of where you might have a psychiatrist, a psychologist and a mental health occupational therapist involved, what is it that each of them must do, but not necessarily what could each of them could do? So I think being able to see how the treatments and support for that person can be spread most appropriately across a multidisciplinary team will in and of itself expand some of the capacity in the current workforce. I don't think it solves all of the issues, but I think a better use of our different disciplines would at least help in perhaps maximising some reach.
And that the MBS would be structured to facilitate that multidisciplinary collaboration and case conferencing.
I think that would be excellent if it could be achieved.
Yeah, okay. And in terms of the... Yeah.
I'm sorry, I don't have to go, but we'll make an attempt to come back within 15 minutes.
Okay.
Because I believe you can continue
Okay.
under those circumstances.
Okay, thank you. And just to the point in relation to the changing landscape since the bushfires and COVID, and the widening gap on the workforce capacity, what could we do to incentivise people to work in the mental health workforce looking ahead in terms of, education, incentives?
Thanks. Firstly, I think that, and I would invite my colleague Ms Soper to contribute to this too, but I think at an immediate level, I think we do need to embed in our education processes, particularly in our tertiary education processes for our different professional disciplines, a recognition of the importance of training for mental health. I think that is a key opportunity. And so for GPs, for example, having a compulsory component of their education which incorporates mental health, I think is probably critical. Likewise with nurses, etc. I think moving it from being optional to being a core component of their education would assist in that respect. I think secondly, in order to retain people and allow them to continue to contribute in the mental health service area, we do need to strengthen our supervision arrangements and our arrangements around the care of our mental health workers. I think those things which can help avoid burnout for our current workers is incredibly important. So looking at what those appropriate structures can be and perhaps utilising things such as our telehealth measures, etc., to expand the the capacity for supervision, particularly for clinicians who might be in rural, remote areas. So I think that would be another way that we could do it. Thirdly, I strongly support, I think the Commission strongly supports, I should make it a we, the role of peer workers, the role of lived experience, and the touch points that they have and how that can be incorporated into our workforce.
Okay. I just need to mention the witness is not covered by privilege. So at this time, thank you.
Thank you.
Okay. So just to go further to the mental health, the care of the mental health workforce and the supervision arrangements of the mental health workforce, have you got any suggestions, practical suggestions of how that might look like in terms of practical suggestions or financial incentives to support the mental health workforce?
Look, I don't think I could purport to go into that area in terms of not being a clinician myself and not being involved in the delivery supervision. It is provided as feedback that we have certainly heard, and specifically around the issue of burnout and but also in circumstances where somebody may feel as though they are dealing with quite complex issues. How can we best support them as they go through?
Okay, thank you.
I just might add some extra things to that. So we've included this in the submission that we put into you. When we were developing Vision 2030, we actually commissioned a report on the workforce, and they came up with 9 key things that would help improve future mental health workforce, including multidisciplinary service models and the expansion, as Ms Morgan said, of the role of peer and allied health workforces. It's on page 4 for you, so I won't necessarily run through all of them, but I'll just pick a few out as we go through. Just to further that piece about top of scope, if we were to develop competency-based frameworks and standards, that would increase capacity, satisfaction and efficiency. So, as Ms Morgan said, you've got the people doing the thing that only they can do, and therefore that provides extra capacity within the workforce. Improvements to mental health education and training, including to the broader health and social services workforces. And the other couple I just want to pull out there are this improving staff safety and wellbeing, which reduces stress and burnout. One of the things I would just share with the committee is conversations around, as we were developing the children's mental health strategy, around the challenges getting child psychiatrists, and because it is such a very difficult field, and when they have any placements coming through, the challenges, particularly in WA, that were put to us were that it is such there's so few of them that every single interaction with clients and with the public was really intense, and so that just caused this incredible stress and burnout. And so people were in and then popped back out again, and in and then came back out. So there needs to be looking at that stress and burnout piece. How can we limit that? How can we provide support to them? Supervision was one that Ms Morgan raised. But additional funding to make sure there's sufficient people just flowing through that particular trail. The other one there, probably worth pulling out, is addressing culture, values and attitudes in workforce development training. Then that reduces that stigma and discrimination. That increases early identification of people, and then that gives kind of compassionate support where needed.
So just in relation to burnout, and given that supervision is one strategy that does assist with reducing burnout in the mental health workforce, given that more and more of the bulk of mental health professionals are in the private sector, the cost of supervision, which is the cost of a consultation for many, because they're seeing, usually a colleague who is expert in a particular area or particularly, end stage career and has a lot of wisdom to impart. Is there any way in which we can facilitate and assist those mental health professionals who are working in the private sector to receive more supervision to ensure that we are not we're preventing our very small mental health, our limited mental health workforce from burning out, given that they're a priority. We need to maintain them, and in fact we need to expand them.
So recognising the importance of the supervision and looking at service models which are delivered within the mental health services system, where you provide supervision, you can actually require that and you can ensure that somebody is appropriately supported. If you're looking at the private system, where somebody will choose to be supervised and we want to try and ensure that they get good supervision, I think it does come back to that question of how do you incentivise and make that happen. I don't have any specific suggestions I can make at that point. It is, if I was to make a suggestion around it, is I think that is an area for quite specific investigation with the particular disciplines. And I would say that supervision would be needed across each of the disciplines. So if you had, for instance, OTs who were involved in the delivery of mental health services, I think that would be appropriate to ensure there was adequate supervision for that mental health component as well. But I do think that for the purposes of today, that strikes us as being something that does need further investigation and quite targeted comments, which is probably why I don't feel in the best position to do it. I think, for instance, if I was an OT delivering mental or involved in the delivery of mental health services, I would, in that role, be better able to articulate what I may need and some structures around it. But it is a critical part of that deeper dive that we would be asking for around all things to do with workforces.
I wouldn't mind adding, we understood through the COVID period there were some supervision aspects that actually increased because of digital platforms. So in the past, supervision had been an individual face-to-face model, and that has expanded out. I don't have any understanding of the efficacy of that, and you would need to investigate that. But I do think that digital platform, particularly in a rural and remote setting, provides assistance. Still don't you know?
No, I think that's a valid point. I think in relation to supervision, it's not more of a choice for some professions in the field. It's more of it's compulsory for professional development and ongoing continuing registration. But it's a cost on the individual, particularly in the private sector. And I think that, and I ask you as well, that given that what ultimately we want is good outcomes for the consumer / patient, is there a potential risk to patients where, if we're not adequately supporting the limited mental health workforce that we have in place, and we're looking to expand that workforce, and knowing that burnout is a risk factor for not only the clinician but also the patient consumer, do you think that we have a role to play in ensuring that all the limited capacity workforce that we do have are sufficiently supported moving forward, particularly with the growing demand on clinicians in this particular period right now that we face since the bushfires and COVID?
I think certainly looking after our current workforce is critical. I think, as you have articulated there, illustrates the various touch points and why it does need to be looked at with more granularity. There are issues that relate to what are the requirements that not only currently exist in terms of supervision, if I want to keep my registration, etc., but should those requirements be increased in a way that would better support the workforce. That is probably a conversation with colleges and with the clinicians involved. If that is the case, if the answer to that is yes, how does a clinician afford it without adding a further impost into the system that then creates a wider affordability issue for the end user? I think that involves conversation and investigation with funding models and funding mechanisms. So I think this is where these key issues intersect with each other, and it's not a one-dimensional answer. I think the preservation and of the longevity of our current mental workforce is critical, both for them as individuals and for the system, but I think it has different touch points which need to be investigated and brought together.
Yep. Okay. Deputy Chair.
Thank you, Chair. Thank you for again appearing before us today. I'm looking forward to your final report being public, because I'm sure there is much more that we're there for us. And I welcome your comments around workforce as an allied health worker myself and as the chair as well, particularly talking about working to top of scope and multidisciplinary teams. I mean, that was always my experience working in acute adult inpatient units as part of multidisciplinary teams as a pharmacist with OT, psychologists, social workers, psychiatrists. And I agree, if we're looking at, in terms of the measure being someone's experience of care, then I think that is a model that it would be, if that was able to be somehow sort of mirrored or replicated. And you're right, in terms of the MBS, I know if a pharmacist participates in a case conference and they're not able to be, as it's structured, remunerated for that participation in what could be critical in terms of that person's care. But I wanted to go to, I suppose, really when we're looking about access and affordability and workforce, they're intrinsically linked. And as soon as someone is outside of a big city, then that access, because of affordability or availability, that problem is only amplified. So I was interested because given the work of the committee and where we could, and I welcome your guidance around where we could sort of, what information we need to know that we don't know yet. Is there, and just having a chance to have a quick look at your statement, here today, is there anything in terms of guidance to our committee where you think that, particularly looking around access and affordability, any information that we don't know that we should know, or that should be available to inform the work of the committee?
One thing that we could ensure is made available to the committee is we did, as Ms Soper indicated, in the course of doing Vision 2030, we had some specific lines of inquiry where we did have the advantage of some external expertise provided to us. So we certainly, in the space of the funding mechanisms, had a piece of work that we commissioned, so we could certainly make that available. So that might provide some assistance. It doesn't really provide the answers. I think it provides, for myself, a deeper understanding of the complexities of what is needed, but maybe of some assistance in understanding it.
No, we would welcome that. Yeah, yes, definitely.
The only other thing I can think of, and it was open for public consultation recently, but we have done a children's mental health and wellbeing strategy. Really happy to send you a copy of the latest version of that to give you an outline of what we were thinking in. I know you were talking before with the department about that 0 to 12-year-old group as a bit of a gap in our mental health strategic coverage, if that's the right way to put it. So we're happy to provide that as well.
Thank you.
Thank you. We probably should wrap it up here because of time, but thank you very much. Would you, if it's okay, we may invite you back as we progress through the inquiry to explore some of these issues. Thank you again for coming here today. The Secretariat will be in touch with you in relation to any matters arising out of today's hearing, and you'll be sent a copy of the transcript of your evidence when it becomes available, and you will have the opportunity to request corrections to transcription errors as well. Thank you very much.
Thank you.
Thank you. Thanks.